Introduction. Setting the clinical context. When evaluating a patient with suspected multiple sclerosis, cerebrospinal fluid analysis serves as a vital diagnostic pillar, particularly when clinical or neuroimaging findings are atypical or insufficient to fulfill the McDonald criteria. The diagnostic value of a lumbar puncture lies in its ability to demonstrate intrathecal synthesis of immunoglobulin G and structural breakdown of the blood-brain barrier. By analyzing specific biomarker percentages, we can reliably differentiate clinically definite multiple sclerosis from normal controls and other confounding neurological conditions. Evaluating blood-brain barrier integrity and total protein ratios. Our first clinical indicator focuses on cerebrospinal fluid albumin levels. Albumin is produced exclusively by the liver, meaning its presence in the spinal fluid is purely a reflection of blood-brain barrier permeability. In normal controls, we see elevated albumin levels in a mere 3% of cases. However, in patients with clinically definite multiple sclerosis, this number rises to 23%, signaling a mild but distinct compromise in the barrier's structural integrity. When we evaluate the ratio of immunoglobulin G to total protein, abbreviated as IgG, TP, we are looking at what percentage of the total protein profile is specifically comprised of these antibodies. While normal control values remain unremarkable or completely baseline, approximately 67% of patients with definite multiple sclerosis exhibit a distinct, abnormal elevation in this specific ratio, providing early biochemical evidence of central nervous system inflammation. The specificity of intrathecal IgG synthesis. To confidently confirm that antibody production is originating inside the central nervous system rather than leaking in from the periphery, we turn to the IgG, albumin ratio and the IgG index. The IgG, albumin ratio compares antibody levels directly against albumin to control for blood-brain barrier leakage. While normal controls display elevated levels in 36% of cases due to various nonspecific factors, multiple sclerosis patients experience a significantly higher abnormal elevation, ranging from 60% to 73%. The clinical utility becomes even more pronounced when we look at the IgG index, which uses a strict formula to compare both CSF and serum levels of IgG and albumin. This serves as a highly specific metric for intrathecal synthesis. Only 3% of normal controls show an abnormal IgG index, whereas a massive 70% to 90% of multiple sclerosis patients display a highly elevated index, making it one of our most dependable indicators of localized neuroinflammation. The Diagnostic Gold Standard, Oligoclonal Banding. The most definitive biomarker in this clinical profile is the presence of oligoclonal banding of immunoglobulins. When subjected to gel electrophoresis, the cerebrospinal fluid of 85% to 95% of patients with clinically definite multiple sclerosis displays these distinct, discrete bands, indicating a sustained, clonal B-cell response directed within the central nervous system. However, as clinicians, we must interpret the remaining data with precision. Roughly 7% of normal controls may also test positive for these bands. It is critical to recognize that this 7% represents patients with other neuroinflammatory or neuroinfectious diseases, such as neurosyphilis, Lyme disease, or subacute sclerosing panencephalitis. Therefore, while positive oligoclonal bands are highly sensitive for multiple sclerosis, they must always be contextualized alongside the patient's broader clinical presentation and matching serum samples to rule out systemic infection.